evening. And you're in France.
Right.
Right, you ready?
Yep.
Yep. Okay, Steve. All right. Good morning. Morena, hello. Good afternoon, good evening, wherever you're from. Candida's here. If you could pop her up as a guest, please. I'm Joel Porter. I'm here with Steve and Ange. Kendall is on holiday this week, so she's going to be joining us next month. So this is Motivational Interviewing and Beyond. Steve, I don't know if you realize this, but this was the month that we began talking about doing this 3 years ago.
Oh, wow.
And from that conversation right at the beginning of COVID, we've been able to share this kind of forum and this platform with a whole lot of people around the world and bringing people together to have discussions and to teach each other about a wide range of things about motivational interviewing. So that's been really cool, and it's been a real pleasure doing this. Tonight's topic is kind of, a little, I don't know if it's off path, but to me it's right in line. It's something I've been interested in. Well, I've been interested in psychedelics for a long time, but psychedelic assisted therapy is something I've been interested in ever since came across MAPS probably about 10 years ago. And living in New Zealand, in Australia, there's just not a whole lot. At the time, there's not a whole lot of access to training, and there's only one organization, Mind Medicine Australia, that provides training right now. So that'll be something I'll be going down before too long, is getting the certification as a psychedelic assisted therapist, because I believe it's coming, because Australia has now clinical trials going with MDMA, and they're going to do some work with psilocybin, I believe, and they've cleared a pathway to do that. And as Australia goes, often New Zealand goes as well. The interesting thing is I got introduced to this idea probably about 15 years ago by a therapist down in Dunedin, because they were doing ibogaine assisted therapy with heroin dependent people. I recently had a conversation with Doug Selman about this, and he said, well, they said they don't do it anymore because it was just so expensive to get. And so you have to have legitimate ibogaine, and then you have to have a chain of custody, and it just costs a lot of money. But even though they didn't publish anything out of it, the therapist said that, they would see some pretty profound result with a lot of people that have been a lot of different kinds of treatment. Full disclosure, over the last probably 5 or 6 years, I've participated in some psilocybin, ayahuasca, spiritual work, psychotherapy work with spiritual and which has only increased my interest from my own personal benefit from those experiences and the reintegration process of that. Certainly ayahuasca is not a party drug, and it's not a drug that they're doing research on, but it was a pretty profound experience for me that helped me shift some things that I've been wrestling with for a long time. So I was really grateful for that experience. It wasn't a lot of fun, but the outcome was good. So that's where I came into this. And as I read MAPS protocol and I saw how person-centered kind of the process is, I just had this thought, I wonder where motivational interviewing could fit into this, either as a pre-treatment step or even post-treatment, as people kind of are in the reintegration and they're coming across things that they all of a sudden they want to change, but they have some ambivalence about changing. Because obviously the spirit of the MI is something that is sort of happens throughout the process, as far as I could tell. So that's where I come into the picture. And I know that Steve was kind of like scratching his head going, well, this will be interesting. And so hopefully hopefully, we can share some information. We can demystify some things, particularly our colleagues here, Steve, and we can just share some ideas with everybody on the panel and in the audience. So that's where we start. So how about we do a couple of introductions? Ange, you want to introduce yourself? You're the one who's driving this train.
I'm glad to be part of the team and support this brilliant team we've got together this evening. My name's Angela Watkins. I'm based in Cardiff. I'm the communication support for the podcast. So if you've got any technical issues, you pop them in the chat. And when it comes to chat towards the end of the podcast, you just let me know if you've got any questions for the team. Thanks. Glad to be here.
Well, Ange is the producer of the whole thing. She pulls all the levers and gets us organized. Steve.
Hello, I'm Steve Rolnick. I've got no interest in this topic, and I've got some interest in the experience that people have when they take these drugs, but I've not got any developed interest on the relevance of MI. So in a way, I'm quite fresh this evening, so I'll be more than happy to be quiet and maybe ask some tough questions later on. But
yeah, that would be great. Absolutely.
I'd rather just hear what people say about the experience itself and go from there.
Okay, absolutely. I don't think we have any people, but we don't have any clients. Maybe there's some people in the audience who have participated that wouldn't mind coming on sharing experience. All right, so we're not all looking at the same screen, so I'll just ask people to introduce themselves, and we'll start with Candida. You're muted, Candida. But famous Zoom saying.
Okay, I'm here. It's Candida Mauer.
Candida. Okay.
Yes,
Candida.
that's fine. I am a PhD psychologist. I've had a lot of personal experience with psychedelics in my youth, and a little experience in my old age. So it's been life-changing over and over again. And that is exactly what drew me to get the training I needed in order to help other people with this. So I am certified to do whatever the heck it is I do. And I'm really looking forward to the research we're going to be doing in Iowa City, Iowa.
All right. Okay. Joshua.
Hi, I'm Josh Bringle. Thank you so much for having me on this webinar. I'm a licensed clinical psychologist in North Carolina in the United States. I've been doing motivational interviewing since maybe 2009, 2010 was when I first got trained. In terms of psychedelic therapy, I recently completed a year-long certificate program in psychedelic therapy and research through the California Institute for Integral Studies. And part of that program included the MAPS training for MDMA therapy for PTSD. And since June 2022, I've been a ketamine-assisted psychotherapist. That's been a relatively small part of my work hours, but I've been doing that for 8 or 9 months now.
Joji.
Thank you. So really delighted to be here. My name is Joji Suzuki. I'm an addiction psychiatrist in Boston. Did my TNT training in Sheffield. I can't believe it's been over a decade. But MI has been a big part of my practice. Most of my career has been focused on implementing addiction treatment programs, targeting principally opioid use disorder and alcohol. But I've really begun to transition more towards full-time research, clinical trials, novel therapies. And I think psychedelics remain an interesting avenue. I come this from as a perspective of a researcher. And so I work with other therapists who have the CPTR training and others. But from the very beginning, it became very clear that the MI approach, specifically the relational aspects of MI, would dovetail really nicely. It provide just a wonderful foundation for this treatment. So looking forward to this discussion today.
All right. Welcome. Glad you're here. And Michael, my friend.
Thank you, Michael Fluop. I'm a psychiatrist in Iowa City. I also did my TMT in Sheffield. I am by no means an expert in psychedelic assisted therapy at all, but Candida, who I work with, approached me several years ago, and we sort of got a ball rolling, and it is rolling. This is incredibly well timed for us. Candida is almost completed our manual for psychedelic assisted psychotherapy, and it's missing the MI piece, which is my plate. But briefly, we have a funded study that we have not yet started, but hopefully it will start within the next few months, targeting with actually comparing psilocybin and ketamine for alcohol use disorder, a small sample. But we're very excited about it. And, we, like everybody else, this is new territory. I think there's a huge role, an obvious role for MI, certainly in the pre-treatment. In our, like many of these studies, we're going to have a number of sessions prior to the medicine day. It's very clear to me that there's a major role there. It's completely unclear to me what, if any, role MI has on the day of medicine. It's somewhat unclear to me what, if any, role MI has in the integration sessions. But I'm really interested in hearing what people think about this, and I applaud you for getting this going, because I think it's something that men should be involved in.
All right. Well, okay. So now this is, as everybody knows, this is unrehearsed and unplanned, and often goes by either Steve or I just asking questions. So in any one of the four of y'all are welcome to begin answering this question. So what exactly is psychedelic assisted therapy, and where did it come from?
There's a long history, and I am sure that Joshua knows this as well, because we both learned it at CIIS, pretty much starting in the 30s in the United States, and a whole bunch of psychedelic assisted therapy was going on in the 50s and 60s, and it was cut short by Nixon in 1970 for political reasons, not for medical reasons. And that's unfortunate. But in the 1990s, Rick Doblin started getting maps together in order to use psychedelic therapy again with research, and Johns Hopkins leapt on board, and there's been a great deal of research at this point. And frankly, all of it's been positive. Up to 70 to 80% of people are getting better. So this is a remarkable new therapy to be working with.
Can you talk a little bit like what is MAPS and
Oh, sure. MAPS is the Multidisciplinary Association for Psychedelic Studies. And they're having a major conference, by the way, in Denver in June, if anybody's interested. 10,000 people are expected to be there. But all of the really big researchers will be there. And I'm really excited to be there. And they've really started the ball rolling, and I give them a ton of credit. Rick Doblin has just been remarkable.
And Joshua, you were going to say something, or Joji?
I'm just going to, no, Joshua, if you want to go ahead. I'm just going to chime in just to step back a little bit and sort of define psychedelics, because it's defined very differently depending on where you look. And traditionally, the classic psychedelics were defined as those with the serotonergic compounds, principally LSD, psilocybin, mescaline, and DMT. But eventually, it got expanded to include other types of, serotonergic compounds, but also MDMA. MDMA is not a classic psychedelic, but as Candida mentions, MAPS really popularized the idea because they can be administered in a similar type of a context. But then fast forward, we now include ketamine. Some people may argue it's not, but historically these were completely different compounds categorized differently, but it's now come under this sort of rubric of psychedelics, which was a term coined by a psychiatrist in Canada. Up until then, psychotomimetic, hallucinogen, and other things were commonly used, but he preferred the term to refer to something that would manifest the mind. So it's really loosely defined. So I think the definition has kind of broadened over the years, which I think is fine. And I think hallucinogen still is used by DSM, but is a sort of very narrowly defined, to a particular perceptual disturbance, which is not even that particularly common anyway. So psychedelic is a preferred terminology today.
Mm-hmm.
And I will just add, just to provide a counter, not necessarily a counter voice, but I do push back against the idea that the efficacy of these compounds have been established. I think it's very, very important that we do not portray it that way. I think it's irresponsible to do so. And the available evidence base, for example, so you mentioned alcohol. We are also doing trials for alcohol for both ketamine and psilocybin. There are 3 trials, 2 for alcohol, 1 for psilocybin that have been published. These are all considered to be double-blind, placebo-controlled, but none of these trials have ever established any blinding. The most recent trial, Michael Bogenschut's trial, 95% knew what they received.
Right.
The MAPS trial, they didn't even assess blinding, but the anecdotal evidence is that there was no blinding. This is true for the cocaine trials as well. So until we have better methods, I'll just put that out there, even though I think all of us believe that they have potential. I think it's really important to not portray that the efficacy is established.
So I got just a curious question popped up, right? Could you imagine being in a clinical trial where they're using something like psilocybin? What's the placebo? And you would know if you took it or you didn't.
Right.
So that's obviously a very big question in the field. Nobody has a really great answer to that question yet. One of the reasons that we pivoted from a placebo-controlled trial to a ketamine comparison was because we gave up on the idea that there was a good placebo. I think there just isn't.
Right.
Okay, Joshua.
There have been, some attempts at that using midazolam and a few other substances. But yeah, I think folks know when they're getting in a trial, whether they're in the control group or the active group, for sure.
Which is fascinating in many ways, because it forces researchers to think about how do we do this in a rigorous way because in some ways the placebo effect is part of the effect and it's not a bad thing. But how do you account for that in a way that's, rigorous? It's a very challenging question on the blinding issue. So
just quickly, in the largest study that's done, the Bogenschutz study, they actually quantified the degree to which both the participants and the clinicians were able to correctly guess which was which, and it wasn't 100%, but it was near close to both.
Mm-hmm.
So we've quantified the non-blindness.
And surprisingly, that was one of the first trials that actually measured efficacy, effectiveness of blinding, which is also surprising. But
I was thinking about Alan Marlette's work years ago around alcohol and expectations, and when he did the bar lab study, and he gave people alcohol-free beer, and then talked to them afterwards, and they were talking about feeling intoxicated, and their ears were getting warm, and they felt more chatty. I just couldn't see, but they were in a group too. But I just couldn't. It'd be a challenge. So I was curious about that. All right. So the idea of psychedelic assisted therapy has been around for a long time, since, like we say, 1939. And I remember I went to a talk by David Nutt in Melbourne, and he was talking about what, Nixon was worried about people taking LSD and not going up to fight in Vietnam or dropping out, tuning in and dropping out. And so that's where the war on drugs kind of got started. And at that time, the US was doing so much of that research, it just dropped completely. And then it just kind of died, and no other US government, was going to pick up that ball and try to carry it again once the war on drugs was declared.
Although I think a lot of people would argue that the indigenous use of psychedelics predates by hundreds, if not more years. So just to point that
100%.
out, I think there's a quite a long history. Yeah.
Yeah. Well, the use of peyote and 5-HT DMT, you know, right off the toad, and ayahuasca and ibogaine and mescaline, all of those were used in ritualized in ways to do that. Absolutely. And to help transform people for lots of different reasons. Great point, Joji. Okay. So it's been around for a while. There's some controversy. What's the current debate? Because I can only imagine. I'm not involved in trying to talk with funders or politicians or the public about any of this. What is the argument against utilizing these substances? Right, they're drugs. They're psychopharmacological agents, just like Prozac or Risperidol or any other drug. What's the argument about not engaging in this research to explore and see if it works?
I think one concerning issue that's popping up in the United States and perhaps elsewhere is that a number of these psilocybin in particular is being decriminalized in different states in America. And, as Dr. Suzuki mentioned, we don't know exactly the efficacy of these substances. We see some evidence that they're going to be helpful for a number of populations, but they're becoming, very widespread very quickly in America. And, I have some concerns about that. I don't want to be too much of a gatekeeper, but I do have this, education and understanding that, these substances really do need to be utilized safely and in appropriate settings and with appropriate structure for them to be safe and to be as effective as possible.
Okay, so there's an issue around access, and then how people might try to do this in their own personal self-help kind of way, or overuse and recreational. I mean, overdosing on mushrooms is pretty much impossible to do, from what I understand.
Right.
Which is, you can compare risks of drugs, and that's one thing. But in terms of like people doing that, one of the risks would be like somebody who is experiencing trauma saying, okay, I'm going to get some MDMA and I'm going to try to treat my own symptoms.
You're right. Exactly. Right. Yeah. And doing it without the guidance of someone who does have, what we're saying is appropriate education. And, as Dr. Suzuki mentioned, there have been a number of communities who have worked with many of these substances for years and have probably done a wonderful job. And kind of our current culture here in the States, that's probably not getting the same attention as this Western medicalized approach. But I think there are some concerns around decriminalization.
The current movement has three sort of legs. One is the sort of therapeutic applications of psychedelics to treat specific disorders, depression, substance use. But there's also, like in Oregon, and other places, it's really about decriminalization for personal use. And then finally, more sort of a religious wellness, they're all kind of related, but I think these are three different streams in a way. I think some people are very, stuck with, maybe feel that the medicalization approach is the safest approach. I think there's a lot of debate around that too.
Yeah. Now I'm noticing that Olivia Finnegan has written in, and she is absolutely right. The problem of monopolizing indigenous folk medicines, and they have very long-standing traditions, and they're doing the healing without the financial aspect. And the financial aspect is huge, really, really big. I mean, I'm seeing, minimum cost for a psychedelic session is being estimated at around $6,000. Well, that's ridiculous.
Oh, wow.
Who's got that? Yeah. Who's got that? So of course we're going to have people doing it on their own, and they're going to be trying to heal themselves, which means we have a lot of education to do, or I don't know what, because it's going to keep happening. I don't think we're going to stop this from happening.
Sure.
So I'm hoping the education can happen.
Sure. Steve, you had a question or a thought?
Just to highlight a comment from Margot about microdosing.
Mm.
I don't know what it means, but I'm interested to.
I think maybe others know more than me. I think the evidence-based answer is there is no evidence based on microdosing. So microdosing is basically using very small, much smaller amounts of these substances than would be a full experience. And it's becoming very common. And lots of people are doing it, but at least from my perspective, I literally know zero. I have not seen a single study on microdosing. Maybe others know.
There was a small study. I saw a small study and it showed no real difference. I don't think microdosing can be studied very easily because it actually requires that the person is either coming in every other day or every third day or something for a small dose from a lab. But how the heck are you going to control what they're doing at home? And so we don't have any good data on microdosing. We have a lot of people saying it's been very effective for them, but it's not research.
It's anecdotal.
Right.
Data.
Right. In the initial psychedelic application in the Western medical field, there were the psychedelic therapy, which was high dose, few experiences of profound experiences, and the psycholytic model where you give small doses in the context of psychotherapy. So microdose in a way is on a spectrum of that, even smaller doses just day to day.
Yep.
Harry does point out in the chat that it may be potentially easier to have a control group in a microdosing study, which is an interesting thought that I hadn't considered previously.
Yeah, I think that speaks to what y'all were talking about earlier about the opening the access to something like psilocybin. And I think obviously people, from what you hear, it's all anecdotal. And I remember hearing, people talking about being in creative roles in Silicon Valley and microdosing on LSD and psilocybin and being able, and doing that. I read an article, an interview with Neil Finn from the Crowded House, talking about in one of his albums, he was microdosing and it unlocked creativity for him. In what he was doing. So I think a lot of that is just going to be personal. And my guess would be that, and Margot, I don't know about your clients. I had one client who was on a ketamine trial here, and he was taking a very small dose for anxiety, and he didn't report much of a positive effect. So he just stopped. And but I think a lot of people that would sort of probably move in and experiment, my guess, with microdosing would be people who are not, in the clinical range. It would be for personal growth and self-fulfillment and enhancing creativity. Right. Those sorts of things they would experiment with there, like people getting a self-help book, but not going to see a psychologist or a therapist. Mm-hmm. So there could be some benefit there if it's there, but it would be great to see. Okay, so any other thoughts, questions about the research, what is and what is not psychedelic assisted therapy before we move into the experience?
I'll just say one more thing. I think, so there are many training programs out there and they have different elements, but that remains an open question also. It is not a settled deal that the concurrent psychotherapy needs to be done in a particular way. The MAPS trial is designed particularly for MDMA, which I think is a very unique compound compared to psilocybin and ketamine. Many of the ketamine clinics don't even do any therapy, right? You just show up and get your ketamine and go home. I think psilocybin trials have been, sort of in between. The original trials that Johns Hopkins did were CBT based. Matt Johnson, he wrote this really wonderful, guide for how to conduct these safely. And it's really, a lot of it is CBT, and their trials use CBT. There is a now trial looking at MDMA plus CBT in couples. So again, what the therapeutic component should look like, it remains a very big question mark. And some of the ways that this was done, in the 60s, from ethical reasons, we would never recommend again. So that's, I think, in a way, that it's an exciting time that we have the ability to sort of shape this. And I really do feel that MI needs to be in there.
Yeah, no, we're gonna jump into that. That's interesting, Joji, because I remember probably back in 1986, 85, I was at university and MDMA was just starting to show up, and it hadn't been classified yet. And I remember it was like coming out of Texas, and they're saying, "Oh, this is, they're using this to do couples therapy research." And then the DEA classified it, and everything changed. So yeah. That we're going to jump into that. So tell us. I haven't been trained in psychedelic assisted therapy, and I'm really curious. And I've certainly read MAPS manual, and I've read the different programs and what they cover. What is psychedelic assisted therapy? How does it work? What does it look like for people that, like me, that have kind of never either experienced it or participated in it?
Candida, before you launch in, can I put
Sure.
my usual rejoinder in here, which is, it feels to me that it's worthwhile distinguishing MDMA from classic psychedelic assisted therapy and the target populations, right? So, and again, this does not come from a lot of experience. This comes from a lot of discussion with people, but it feels like there's a difference between using MDMA, primarily targeted, the research is targeted to people with PTSD, who are not available to participate in effective evidence-based treatments for trauma because those treatments are too traumatizing and too triggering. And MDA allows them a pathway in to be able to access those evidence-based treatments. So it really is a medication-assisted psychotherapy, very much linked, right? If the medication allows for the psychotherapy to happen. With classic psychedelics, it feels like there's a bit of a difference. It feels like the psychedelic experience itself can be therapeutic and transformative, especially if there's good integration afterward. But it's that, and that feels like a big difference. So it feels to me like it's useful to first recognize that difference and perhaps to constrain the discussion to one or the other. And I would vote for constraining the discussion to classic psychedelic assisted therapy and putting MDMA a bit aside.
Good point, Michael. This is I'm really enjoying this conversation. We're only 30.
Yeah, I think that's, I think there are many ways to parse it in a way, right? Because also one of the lessons that I feel has been really important is this concept of preparation, integration. And in my world in substance use disorders, we could have been talking more about integration work. Treatment is so fragmented. You go here, you go there. There isn't this sense of continuity. But when I've spoken to therapists about this, they really resonate with this idea that what you learn in one intensive sort of like a residential treatment, we should be talking about how do you integrate that. And so I think there are many similarities in addition to differences, but I hear you, the MDMA I think is quite unique compared to the others.
Mm-hmm.
I agree. I'd say the MDMA, excuse me. Thank you. The MDMA training that I received is exposure therapy to the max. The amygdala is downgraded. People are able to access these traumatic events and really process them in a way that they're not able to do otherwise. So I agree. That's a very unique experience, and I'm happy to set that aside for the rest of the discussion also.
Okay. I think it would be helpful maybe, and this may not relate to many of us here. There's a difference between a European model and the American model. The American model so far has been very much cognitive behavioral and kind of hands off. You're providing support, you're helping people get through rough patches, but essentially you're letting them have their experience. The European model is much more, they call it psycholytic, meaning they're doing psychotherapy during the actual experience. That actually is my preferred way of working. So I'm not going to be doing the traditional American model, simply because I think we're given this precious moment of openness and unbelievable expansiveness in a person's psyche. Why wouldn't we use it to the best availability that we can?
Okay. Yeah, I remember listening to, and I was just drawing a blank on his last name. He wrote a book, the journalist Michael.
Oh, Pollan.
Michael Pollan. And one of the things he talked about, which I think resonated with what was said, was that what sort of psychedelics can provide, and I would even think MDMA as well. It's like, giving you a fresh field of powdered snow to ski down a very similar terrain. It's all brand new, so you can look at it in a new way. I think about the treatments for PTSD. Moving on to that side of the fence, Michael, that used to be all exposure-based treatments. And you had to talk, you had to get it out, you had to tell the story, release the emotions that were connected with it. And over the years, over the 20, 30 years now, there's trauma-informed yoga. EMDR came on, and people were like, there's no way just waving your finger in front of someone's eyes is going to make a difference. But, it is effective for a particular group of people. The data is still pretty promising around that. I think there's probably a place, and for doing some very good clinical hypnosis as a way of kind of letting somebody dissociate from the experience while at the same time participate in the experience. But it would be quite skillful. My dissertation was around that area, but I think there's something about the MDMA experience, or even the psychedelic experience, that is a different kind of exposure therapy. It's a different kind of it, where they're gauging the exposure. They're in control of it.
And not necessarily with classical psychedelics. Things pop up. Things just pop up that people have had no memory of, and suddenly here's this memory, and they're going, "Oh my God, I was abused when I was a child." I mean, that does happen. So, and that isn't a controlled situation.
Yeah. Well, I was reflecting back to my own experiences.
Yeah.
So, like I said, I've never done this. Now, that's really interesting, which brings in an idea. How do you discern something like somebody saying, "Oh, I experienced this as a child," going back to the implanted memories research of Elizabeth Loftus and University of Washington? How do you, in working with somebody who's having that experience in the way that you're talking about, doing psychotherapy in the moment?
I've had a lot. I did my dissertation in hypnosis too, so
we ought to talk.
We're talking the same language here. I've always looked at it as, if it did not happen, it is still coming up and it has metaphorical meaning. So I will look at it as a metaphor. I will never say, "Oh, yes, this happened to you." I will say, "Wow, I'm sorry that you're having this experience. I wonder what we can get from it," right? How can we understand it in a more profound way? So I don't ever support suddenly this memory is coming up in any way other than this could be a metaphor.
Yeah. Okay. All right.
Yeah.
Okay. Sorry.
But
Go ahead if anybody wants to jump in.
But I think this points to, I think sometimes some of the adverse effects of these treatments are somewhat downplayed or minimized, and I think that does our patients disservice.
True.
Just as being pointed out, memories can surface, and with MDMA, for example, the people feel there's a whole podcast called Cover Story and people's experience with it. But people talked about during treatment, it's like their chest is being ripped open, feeling very vulnerable, but then what do you do with that? Some of these participants felt like after it was done, they were kind of left to kind of fend for themselves in that vulnerable state. So that's why, on the one hand, we know that these compounds can be powerful, but what that also means, I think, is that we need to be very, very careful about how they're administered, the context in which they're used. Yeah.
Yeah. And yes, absolutely. I agree with everything you're saying. And once again, it's not like we have total control in these situations. We just don't. And things will happen that we absolutely cannot predict. It just happens. And as a really good therapist, I hope, people are able to be spontaneously and warm-heartedly, and that is very important, as it is in MI, right? There for the person and help them get through the situation as well as they can.
Absolutely. I mean, there's anything, any good things can cut both ways, can it?
Mm-hmm.
And I remember back in the 80s when it was, expressive therapies and cathartic therapies, and body work and breath work were really involved in Joji, clients, having these very intense abreactive emotional experiences, and then the session's over.
Yeah.
And they go home. They've been psychologically unzipped and the person hasn't been able to do the reintegration work.
Right.
And so then they go back out, in that way. All right. So let's get into the what we know about the client. We'll just say the person's experience and how we've come to understand that. And what your experiences have been in working with people when they were participating in the therapy. What do you see? What do you hear? How do you see things unfold? It's a very broad, open question. What's it like? Joshua, you want to start, or Ken?
Okay, go ahead. Has anybody besides maybe myself and Joshua actually had the experience of working with somebody in these situations?
No, I haven't.
No, so we're planning trials, but no, we haven't directly worked with patients in that.
Okay. Have you had that experience, Joshua?
Yeah, I've done ketamine-assisted therapy, preparation work, sitting with people we do IV infusions, and then doing integration work afterwards.
Yeah, what's your sense of what happens? Because to me, it's kind of, there's a lot that goes on.
There's a lot that happens.
Absolutely, it's a big question.
So when we have infusions, we infuse anywhere from 0.5 milligrams per kilogram of ketamine to a milligram per kilogram of ketamine over 40 minutes. During those 40 minutes, the patient wears eye shades and has headphones on and listens to music, which helps to structure the experience. During those 40 minutes, there's typically not a lot of interaction with me or the other folks who are present. Sometimes people will take the eye shades off and ask a question or check in or make a statement out loud about what they're experiencing. We call those anchor points. So they might say, oh, I'm feeling this right now, or I'm present with this right now. And we'll make a note of that to kind of jog their memory later. But during the infusion, typically it's a contained internal experience. After the infusion is over, we encourage folks to keep their eye shades on and kind of stay under with the internal experience for 10, 15, maybe 20 minutes after the infusion ends. And then either the psychiatrist I work with or I sits with the person and talks and just sort of has a, how was that kind of discussion? How are you feeling now? And we do some questionnaires afterwards about whether they're experiencing any dissociative symptoms following the infusion. And kind of what I consider that's very therapeutic, I think, for folks. but then folks come back within 24, 48, maybe 72 hours to do a therapy session, integration therapy session.
And what sort of self-report do you hear, Joshua? Post intervention?
Yeah. There are some similarities that folks report in terms of their experience with the ketamine. And then there are also, certain patients have an experience that's more visual. Certain folks have an experience that's a bit more emotional. So there are also some differences kind of between people.
Sorry.
No,
I was going to say, in a session like that, how does it start? How do you set that? Do you say what is it you're going to be working on today, or what are you going to be thinking about, and then you provide the ketamine, and then you kind of sit and observe and be there in support?
Yeah. So there always is a period of time when folks arrive where they're talking with one of us, or maybe both of us. Some people are very formal about, this is the intention I have today. This is what I've thought about since our last session or since my last infusion. And this is some of the work I've been thinking about, doing during this infusion. Other folks have found that even if they sort of set an intention, that during the infusion, they may think about something, completely different that's still meaningful to them. But it's hard to dictate exactly what the experience will be about once the infusion starts. So some people really enjoy the process of getting centered, stating an intention, and then having the ketamine experience. For other folks, it's not quite as formal, and we don't provide too rigid a structure around that period of time. One thing I will say about our setting is that it's pretty medicalized. So we're doing an IV infusion. We're checking blood pressure during the infusion. It's in a medical center. So that's kind of a limitation. I think some folks who have some medical problems appreciate that level of monitoring. So that's another sort of piece of our puzzle, is that there are nurses there. There's a doctor there. Often I'm there. And so it feels like coming to a medical center to have a
no lava lights and black lights and posters on the wall.
Yeah, right.
Incense burning sort of thing.
Yeah, more hospital bed and fluorescent overhead lights. But,
Oh, God.
So yeah, our setting isn't ideal in that sense, but I think everyone adapts to it very well. And I think, we do create, mentally, I think, a very good process and sort of container for holding this experience for folks.
Okay. All right. And coming down to our next psychedelic assisted therapist, what do you observe? What are your thoughts?
I've had a lot of experience in Brazil, where it was legal for me to be experiencing both as a guide and as a receiver of the psychedelics. One of our professors from Johns Hopkins took a small group of us down there. And it wasn't traditional. Like, I know how you were trained, Josh, and it certainly wasn't the way we were trained. But we had a really beautiful man who guided our ceremony and who had been trained as a shaman and also had 2 PhDs. So very bright man, remarkable human. But here's where it didn't work. There was no setup in terms of here's what you might experience. And that is a really important piece of preparation, is saying, okay, you might get scared. And if you're scared, here's the way to handle this. And you teach people breathing techniques. You teach them how to relax their entire body, head to toe. You teach them some basic centering techniques, grounding techniques, because people can feel very scared from time to time during this. And especially at the beginning, because things can get going very quickly. And suddenly there's all these things kind of coming at you, right? And there's visuals and there's thoughts, and they're moving very rapidly. And that can be frightening. So you prepare people by teaching them various ways of calming down. And actually hypnosis can be a part of that too, by the way. So then they come into the room. Our plan at this point, I think we're going to have an actually pretty good comparator, because the ketamine is going to supply them with some kind of a real experience. And we'll be comparing that with the psilocybin experience and seeing what happens with alcohol use disorder. So it's pretty exciting. We're hopefully breaking some new ground here. And they're going to start experiencing whatever it is they're experiencing. We certainly ask them what their intention is. So that's where MI can come in, I think. That's in the pre-treatment. You're setting up the ideas about what they're there for, what they want, what they're hoping for, et cetera. Obviously, you're taking a good history and all that kind of stuff too. We are in a hospital setting, but we're making a really nice room with low lighting and comfortable furniture and the Hopkins kind of setup that you've seen, Josh. And music is playing. They're wearing eye shades so that they're in darkness. And the music is actually constructed to help the experience expand and become, more beneficial, I guess is what I would say. The thing about psilocybin is it's going to last anywhere between 5 to 8 hours. So you're sitting there a very long time. And it's really important that the therapist is in tune with the client, is really working with that person. Even if you're not saying anything, you are tuned into what they are experiencing. You're watching their lips, you're watching their face, you're watching their movements, you're being very aware of what they might be experiencing. If they're tensing up, you might even ask, what's going on? Are you okay? What's going on? That kind of thing. So there's an evolving experience while it's going on. And of course, they are having their experience. I mean, obviously, right? And my job is not to interrupt that. My job, as I see it, is to make that experience as good as it can possibly be for them. And whatever I can do to help them experience this fully and profoundly. Then there's a really beautiful time. They're starting to come down from the experience. And I'm going to say that's like 5 hours into it. And I think that's a great time to start doing some kind of integration, because they've had all kinds of thoughts, all kinds of new ideas about what their life is about these experiences they've had. And that 1 hour time period or whatever it is really precious in terms of helping them to cement some of what the experience has been. I'm taking notes like crazy during that time, by the way. I'm certainly asking them if they would like to write something down, or if they'd like to speak into my telephone, and we'll have a recording of it, whatever. And then they come in the next day. So 24 hours later, and we are doing more integration around all the issues that came up during that day. And then there's another integration session about a week later. So it's not ideal, honestly. I wish the integration sessions, I wish there were more of them, but that's what we've got.
Okay. All right. I'm aware of the time, and I want to take a little bit of a pivot and get into motivational interviewing. There's, again, we all could talk about this, at least a few of us could certainly talk about this for a very long time. So I was in a recent webinar that Bill Miller put on, and he was talking about the research and what the research tells us about motivational interviewing. Also shared some slides about the upcoming 4th edition of the motivational interviewing book that he and Steve have pulled together that's coming out this year. And he shared a definition of motivational interviewing. And Steve can let us know if this is the one that's in the book, but it says motivational interviewing is a particular way of talking with people about change and growth to strengthen their own motivation and commitment. Right? So the first time I read that, I said, well, they could be talking about any kind of therapy. And then there was like, oh, a particular way. And then that's when you unpack MI. But we're talking about change and growth to strengthen motivation and commitment. And so as you guys are talking and I'm listening and I'm thinking about this definition, it seems exactly that's what the goodness of fit is, because we're trying to help people change and grow and become more consciously committed and motivated to make changes in their life. So what are your thoughts about then Michael?
I'll just quickly add, and the place where I feel that the MI therapist could really shine is that people who are skilled at MI understand what helping means, right? That's such a central concept in motivational interviewing. What does it mean to help? And so in many of the trainings, there's a big focus on being non-directive, but that's actually not exactly true, right? There's a directionality to therapy. And so I think a skillful MI therapist understands how do you maintain the client-centered approach while at the same time balancing this sort of directionality to the therapy. I think skilled MI therapists know how to navigate that sort of tension.
No, that's at least in my tenure with MI is that, directionality was part of the definition originally, and then it got dropped off, and then it became a non-directive, equipoise, neutrality, and my understanding in reading Bill's slides is directionality is going to get kind of articulated again. Michael.
I was going to say, as we talk about this, it's the continuum that Joji mentioned earlier on of sort of, and that I think of as three specific aspects of this, right? Preparation, the thing that happens the day that the person is actually experiencing, and integration. And the truth of the matter is, from an evidence-based perspective, we know essentially nothing about the question that we're talking about, right? We know nothing about the effect of motivational interviewing in either of those three contexts. And that is also rich. I mean, this is an exciting time because there are really simple questions we can begin to ask from the men's community and MI researchers about the efficacy of MI in each of those three phases. And these trials are going on all over the place. I don't know, the last time I looked was months ago, but there were something like 80 clinical trials going on with psilocybin alone, I believe. So anybody who's anywhere near an academic medical center has access to people who are doing these trials. And given how hard they are to do, the more we can sort of add on little components to those trials to understand some of these things, the better. If we could do just like does an MI pre-treatment session do anything? Just kind of randomized before the randomization, that kind of stuff. But as we talk about this, I think it's a very different thing to say, what is the role of MI during drug day versus what is the role of MI in integration versus what is the role of MI in preparation.
Steve, you're having a bit of a reaction up there. What's going on? What are you thinking about?
No, I think both you and Joji have been very clear about this definition of MI, which that's correct. And that is how Bill and I are viewing it anyway. That's just our voice. And I think Joji's description of the directional nature of MI was beautifully put. So I've got nothing to add there.
Okay.
Listening to this, I'm nervous. I'm really nervous and worried. And I found Candida and Joshua's descriptions incredibly vivid, high integrity, interesting, thoughtful, conservative, caring accounts of helping someone through a very vulnerable time. Okay. And so in your hands, if this was in your hands, I think this is a very interesting development. I feel very nervous about the widespread use of this, given the vulnerability of that people will be experiencing when they're high, so to speak. And I'm slightly shocked at enthusiasm for it in the same way that I was shocked at enthusiasm for MI, to begin with, to be perfectly frank. That, you know, and I've had a lot of experiences with these drugs when I was younger, okay? And I've seen people being harmed. And I've listened to this conversation tonight, and it's reinforced a sort of a delinquent ex-academics fantasy about wanting there to be a field called harmology, because the extent to which I hear in my sort of network here in Wales of people being dogmatic about how to speak to somebody about trauma is truly shocking. Mm-hmm. And so now we're talking that people are using these drugs with people who traumatized, shocks me. And I'm comforted, as I say, by the high integrity descriptions of Candida and Joshua. I put people in their hands, but the widespread use of this strikes me as premature, potentially harmful, and I'm worried. And that people are moving into controlled trials of something without really understanding what it is strikes me as premature. And MI has been vulnerable to precisely that enthusiasm 20 years ago. So, and Miller and I don't altogether agree about this, I should say, but I feel that there was a too great a rush to do controlled trials with this dose of thing called MI, without really being very clear about what the experience was. And if I was nervous about that, and there's now 2,000 plus controlled trials on MI, apparently, which I don't find impressive. I find it kind of a little bit more alarming, to be honest. In this field, to proceed with a controlled trial without clarity about how vulnerable might people be feeling, what is the experience they are having, strikes me as premature and worrying, because then if there's a positive result, leaving aside this issue of the placebo and how you define it, then apparently it's effective. There's this magic dose of the stuff, and now, ever widening range of people will start using it. So I'm a nervous guy listening to this, and the enthusiasm for controlled trials in the absence of clarity about what the experience is, how MI might be helpful during the experience, as Candida is just what she's described is extremely delicate and subtle and thoughtful. And I don't see a good, strong fit with MI there. What I sense is tremendous humanity and kindness and delicacy and sensitivity. But that's not MI. I mean, of course, MI might be like that, but so before and afterwards, I think there's tremendous potential if it was in the hands of competent people, because MI is a conversation about change that makes sense to you. And I can imagine that conversation happening before and afterwards. Mm-hmm. And I'm not worried about the neutrality issue, because, for example, today I had a conversation there happened to be with elite sportsmen, but I had conversation with two elite sportsmen on the same issue, the same change issue. One of them I was completely neutral about. I kind of feel it's entirely up to you. The other one, I had a strong vibe that it was a good idea to consider this change. Trust me, right? And I was transparent with him about this. So, the skilled MI therapist is, as someone has already said, I think it was Joji, the skilled MI therapist is very sensitive to whether they are going to really encourage change talk in a particular direction or stay neutral. And that's a beautiful and highly skilled feature I think it was Joji who said this, of helpfulness. What we're talking about is trying to be helpful to people. And I don't think we need to make it too complicated. And I hope that MI4 has made that helpfulness much simpler. So I can see potential here. Joel, I'm going to stop quite soon, but I do want to say, Joel, I think you've been outstanding tonight. I just think you've been so lucid, and I haven't wanted to say anything because you've just been on the ball all the way through. But perhaps I will just say that so I can see potential there before and afterwards in thoughtful hands. I can see huge potential for a delicate and sensitive and constructive conversation about what sort of change makes sense to you, and how can I help you talk about that in a constructive way. An outsider will say, well, that just sounds like you being helpful, and it is. And to do it skillfully, MI's got a lot to offer. I think a tremendous amount to offer. But my every sense listening to this conversation tonight is about modesty and, frankly, horror at the thought of people running with us and harming people. And I would want, if I was a sort of if I was going to live a couple more times, I'd start a journal of homology. Anyway,
so Steve, on the one hand,
yeah, go for it, man.
I'm not going to do that, but no, I think everybody was nodding their heads and they were heeding your caution, and 100%. When you said that one session of this cost $6,000 and psilocybin becomes, accessible publicly, there will be some bad actors, as people said, that are going to say, oh, I can do this for $200 or $300. And we're going to see that for sure. Would anybody else like to respond to what Stephen said?
Someone suggested, Joel, that you've been microdosing. Great comment. I'm not saying anything.
It's a little bit early for that,
You've
a little
been
caffeine. I microdosed on some caffeine. How's that?
You've been lucid and fantastic, Joel.
Thanks, Steve. I appreciate that, brother. So what are your thoughts?
Joel, I'll just say, I think, Steve, you should be worried. And the more you know about it, the more worried you're going to be. I mean, I don't know if you know what's going on in Oregon right now, but, Joji said in the beginning that one way to think about this is that they're for treatment for illness. Can you hear me?
Yeah, you're slightly muffled, but I'm with you.
And another way is just kind of more for wellness or recreational use. In Oregon, you may not know, as of January 2023, it was legalized to the extent that, and they demedicalized it very specifically. So there's a training program that you have to go through. Canada, I think it's 100 hours or 120 hours.
You got to have a high school education.
You got to have a high school degree.
Right.
Okay. A high school degree and 120 hours of this thing. And then you can be a guide in Oregon. So in some ways, the horse is definitely out of the barn already in some areas. Mm-hmm. We haven't talked about timeframes, but in the US, most people think MDMA is probably 2024-ish, 2025 FDA approved. Psilocybin, probably 27, 8, 9, something like that, FDA approved. And we need to start thinking, what the workforce is going to look like for states that are not as liberal as Oregon, but if this is going to be used as a therapeutic treatment approach, we're still in the infancy stage of developing this.
Yep.
I will say that there's an unofficial collaboration right now between Yale, Hopkins, and one of the California groups, where they are working on a joint sort of best practice psychedelic assisted psychotherapy curriculum. But we're really at the beginning stages of something that, whether we want it or not, is rapidly moving. And we are very Canada is absolutely right that it was stopped in the 1970s for ridiculous political reasons, but there were also lots of reasons why that got stopped. We blew that period. And we had an absence of this potential, really valuable asset in understanding how the brain works and fails for 30 years after that. We are at risk of blowing this one big time. And especially if since we're now at that sort of peak of, expectations in the hype cycle. So Joji's sense that, hey, wait a second, like, is very much needed among us. Like, we got to recognize that the hype cycle, it's probably not even near peak actually, but the hype cycle is going to be big, and so we're setting ourselves up for a big fall.
I remember when I moved to New Zealand in 2002, there was excitement because I had motivational interviewing training, and the thinking was at the Alcohol and Drug Service that I'd give everybody one session of MI and they'd be okay.
Oh, wow.
Right. And I was like, well, it's not going to work that way. The hype, as Steve was saying. And one of the things that often does happen with interventions is dissemination comes way before efficacy is confirmed. Because people either are grifters, they're trying to make something out of it or make a name for themselves, or they just want to get it out there as soon as possible. And they make claims that aren't substantiated. So you got to be, there is caution to be heeded for sure in this area. But, and going back to the MI part, and what Michael was saying, I could see, that there could be a place certainly with people in the right circumstances, in the right trials, with the right people, where, coming out of an experience like that, all of a sudden I have this awareness that I have to make some serious changes in my life. And so if I'm in an alcohol treatment program, one of those changes is what? I'm going to need to find new people to hang out with. And I have some ambivalence about telling my mates in the pub I can't be there to watch the rugby on Friday night because I live in a small town in New Zealand and that's where everybody goes. So there's a place for MI in there, I think.
One clinical experience I've had is when folks come out of infusions, they often say, or a lot of folks have had the experience of during one infusion at least, of saying, I see things a lot more clearly now. I know what's important. I'm seeing my values a lot differently. I'm able to cut through, a lot of the BS. So much of what I spend my day worrying about, I'm just shedding right now, or I shed, during this infusion. So I think that clarity of, what's important, what do I value, is kind of a common thread I've seen throughout a number of patients that I think is really useful in helping people say, this is what's most important. This is a direction I need to move in.
Wow.
Okay.
Wow. I mean, Joshua, that's an ideal starting point for MI. I was with someone today and I had to go to the loo, to the toilet for a while, and I left him with a question. And then I came back and I found him looking out over the sports field with tears rolling down his eyes, right? Now, he was having a hell of an experience, right? Now, if you just equate that crudely to what you've just described, someone has an incredible experience, a profound experience, then it's a beautiful privilege to sit with them and ask the question, what does this mean for you? Okay. When you ask that question, they start talking about change. And if you don't push them and you get out of their way and you contain them and help them feel safe, they will start to clarify the path ahead. And I think what I've just said now is that the MI4 book in a sentence, if you like. That clarifying the path ahead for themselves is something that's a real privilege to be part of. And so I feel there's tremendous potential in the use of MI helping people come out of this experience, no question. But for the widespread use, I mean, I think Michael's articulated that very well. It's a worry, big worry.
There's this trope. There's this trope in psychedelics that, oh, psychedelics are 6 months of therapy and, you know, one trip or one experience. But I think, you know, what I just described is kind of the kernel of truth in that trope. Is, you know, you really can see people get focused and say, this is some clarity that I just either I've denied, or I haven't really realized before, I haven't wanted to face, but, you know, here I am. And it does lead to some very rich work.
I'm very curious, Steve, if the MI4 book would reference the quantum change concept that Bill has talked about, because I feel like that really has, you know, it's helped me to sort of conceptualize one potential mechanism for psychedelic treatment. And, you know, Bill sort of outlines the conditions in which the sort of the quantum change event may have occurred. It's a discrete event. There's a sense of benevolence, empathic, you know, sort of genuine positive regard, a sense that there's no turning back. There's a shift in identity. And if you look at some of the accounts of people who have gone through this treatment at the Hopkins trial, for example, for smokers, and for me as a former smoker, you know, when I quit smoking, there was a shift of my identity from a smoker to a non-smoker. As a smoker, it's hard to envision ever being a non-smoker, but part of becoming a non-smoker is that shift in identity. And a lot of people talk about exactly what sort of Josh is talking about, and others, the sort of shift that occurs during and immediately afterwards.
Wow.
There's a real felt sense of change, and it may be subtle, but that really changes the trajectory of your life.
What a superb idea, really. And no, we didn't touch on that in MI4 at all, but I think this is a superb idea, and it's dead relevant to the topic we're discussing tonight. That's for sure.
So, you know, I can bring in some personal bit to kind of add to that. Now, I wasn't in a clinical trial. I was in a setting with a fellow who'd been trained by a shaman from Peru, and, you know, was very skilled at what he did. There were didgeridoos involved, and the music was great. But I can tell you that the experience that Joshua just described was one of the benefits that I got out of that, where the clarity in my life that I saw and the things that I'd been hanging on to and not letting go, I could find a way to release them. Now, the experience of doing that was quite intense in terms of where my mind went to find that and to do that. But then the reintegration work, now this would have been 5 years ago, continues today. It was a peak experience in my life, like finishing my first marathon that I ran, like being at the birth of my children, all of those kinds of things. It's something that I draw from today that is beneficial. Certainly not something it's like, oh, I want more of that. It's like, okay, I had my experience and I'm good. So that is there, right? Now, I couldn't imagine of doing that, getting some ayahuasca and going and getting a hotel room and laying on the bed, you know, and being there by myself, because it needed to be a facilitated experience, 100%.
Mm-hmm.
But that would be my fear, is that people are going to treat it as self-help in that sort of way. Yeah. Because it could be dangerous. It could be incredibly dangerous, which, as Michael would say, could tip the balance really quick to, we need to shut this whole thing down because people are out there killing themselves or dying doing this. Okay, well, look, I'm aware we're at 7:25, and I feel like we just kind of got underneath the iceberg in some ways, and we're getting to the body of it. I want to give everybody ample time, and Ange, I'm really curious about your thoughts as well too, as to if there's anything as we're winding up. I mean, I'm happy to stay on for a little while longer if we want to keep talking. That's fine, but I know people have things to do and need to be places, and so you can just excuse yourself as you need to. But I'd love to hear some closing thoughts from everybody. And how about I'll try to go in reverse order than we did introductions. So Michael, how about what are your closing thoughts, takeaways, ideas?
I had a little light bulb go off just at the last part of the discussion, because it seems I was kind of struggling to think about the role of MI in these three discrete areas. But I think this idea of like the experience being likely to clarify values that really sets the stage for the importance of MI and integration. And I really appreciate that light bulb going off in my head. So thank you for that. And this is a great discussion, really well timed. Thank you.
Yeah, no, this is why I love these conversations, because we don't think we have answers. We just got questions and ideas. Joshua, how about you? What are your thoughts and reflections?
So I'll make a plug for the program I just finished, which I think was rigorous, paid attention to a lot of the ethical concerns that we've discussed today. The director of the program is a psychologist named Janice Phelps, and she wrote an article in 2017 in the Journal of Humanistic Psychology called Developing Guidelines and Competencies for the Training of Psychedelic Therapists. And competency number one is psychedelic therapists should have an empathetic, abiding presence. And competency number two is they should enhance trust in the process that they're undertaking. And the MAPS manual has similar language in it, but I think relates very well to the work that we all do. As part of a paper that I wrote that I'm still developing, I read a lot of Rogers, which I hadn't done for a long time.
Right.
And I was really struck by how simple it was to read him again. It'd been maybe since graduate school since I'd read a lot of Rogers. And I think we have a unique skill set in terms of being present with people that's unique, and that really maps on to a lot of the language that people who are thinking a lot about psychedelic assisted therapy use. So, that's why I'm kind of here is thinking about how do we train psychedelic therapists, and how can we share what we know about being with people with this burgeoning, new field.
And Joji.
I really appreciate this discussion. So it's been very thought provoking, and so thank you, everybody. Quick thoughts. I think number one is that agreeing with what Josh just mentioned in terms of the MI just provides that just solid foundation, but also we know how to teach it, or at least we've thought a lot about how to teach, and the frustrations around teaching a skill. Right, it's not just sitting through a lecture, and I think that's a big difference with MI training is we understand that very deeply. The other is that we know how to measure if the therapist if there's fidelity. And I think that's a missing part, I think, the existing research. And because we are so good at that, I'd love to know, you could just do a mighty coding for a bunch of these trials and see if that predicts, better outcomes or not, whether they were trained in MI or not. So I think I always have fun geeking out on motivational reviewing, and this has been just wonderful. So thank you for the opportunity and for the invitation, Joel and others.
Oh, no worries. All right. Candida.
Yeah, I'm very naive about MI. I've read a little bit, and that's what I've done. And it seemed very familiar to me. So I think I've practiced it kind of because it's just a part of being a good human being and a caring, compassionate human being who really tries to help other humans change and grow. So this has been a really good experience for me in terms of integrating this work in a more systematic manner. And I'm excited to see where it goes. And I'm going to be counting on Michael Fluop to put his piece in here.
Well, I'm sure Michael's an excellent MI trainer, so you're lucky to have him next to you. Ange, what are your reflections on this? What are your thoughts?
I just found it really fascinating conversation to to be a part of. And I think it feels like it's a start of a conversation. I think there's, judging by, I think everyone on the panel had more to say, and judging by the conversation taking place in the chat, that some great links, comments. So thank you for your contributions, everyone, and we'll make that available. Some really interesting points from Michael Clark. You brought that up quite early about MI's need to enter this field. You said, from my perspective, is to ensure it stays and becomes client-centered. So the client's voice should have a big impact on the destination. I think, yeah, MI, although, you know, I'm a novice, I think MI's got a part to play in this. So yeah, thank you for letting me be part of it.
All right. And Steve, if you have anything else you would like to add or reflect on or put out there.
First time I've ever thought about geeking. Using this word geeking. So, you know, am I a geek? No, I feel there's a clear hypothesis here, which is that the more skillfully this experience is wrapped around by a conversation that is MI consistent, the better will be the outcome. There's a clear hypothesis there, and I'd predict that to be the case. And it takes me all the way back to what we know about what used to be called common factors across treatments. In other words,
Right.
The essence of helpfulness is something that we, I think, have approached in MI, and this should predict better outcome here, and is one of the most important ingredients. Might not be the drug, it might be the way that you help the person integrate the experience.
Yeah, I appreciate everybody's time and willingness to share themselves, their research and their experiences, and have this conversation. I think within the MI community, it makes a lot of sense that, you know, we begin this conversation and you know, heated as we all do, with caution. You know, psychology, psychiatry are young sciences in general, and we're still trying to figure things out through trial and error and deductive reasoning. And so this is a brand new area as well too, that could go really well, it could go really, really bad. And it needs a lot of ushering in and guidance with people such as yourselves who are funded to do this kind of research and that have a voice at the table. I look forward to the future of it all. See you, Yoshi. I look forward to the future of it all. I look forward to getting my own training as a psychedelic assisted therapist and bringing what skills that I have into that frame. And because I, as Michael, as you were saying, it's coming. The horse is bolted, and it's coming. And my fear, like any other kind of treatment, particularly working in addictions, is when evidence-based treatments aren't getting implemented in an effective way, people get hurt. And I think it's important that you have people ready to go when things enter the field, because otherwise people will pick it up and have very little education, very little training, and they'll be guiding people on psilocybin drugs. So I think we need to have cautious optimism would be my thinking about that. So I'm happy to hang out and talk a little bit more if y'all would like, or we can just say goodbye, and that's fine too. It looks like people are kind of dropping off anyway, so we might as well finish up and call it a conversation. So this will be up on our YouTube channel in the next couple of days. The podcast will be out in a couple of days, and hopefully it'll reach people and open up their thoughts and minds. So thanks a lot, Michael. It's great to see you. Joshua, it's good to see you. Very nice to meet you, everybody. And Ange and Steve, it's always a pleasure. I'd love to talk more about hypnosis with you sometimes. Talk about something that's gotten a bad rap within psychology.
No kidding.
With a lot of bad actors. It's very similar.
Exactly.
It's very similar. There's a difference between doing clinical hypnosis and, putting somebody in a trance and getting weird. Yep. Hope to see you in Copenhagen too, Joshua. I'm pretty sure I'm going to be there 100%.
Thanks so much for doing this, guys. Really
Yeah, no
Thank
problem.
you so much.
Thank you. Thank you.
Such a great opportunity.
Thank you so
Okay,
much.
cool. All right. Well, we'll
Bye-bye.
see everybody later.
great to see you.
Bye, guys.
Bye.
Bye.